Okay, good morning, everybody. I'm Mark Schwartz, and this is Lori Galperin, and wishing you a very good morning from Monterey, California. So, just in way of introduction, the background of this workshop is that I was taking a recent retraining in EMDR. Originally, I was trained with Francine Shapiro 20 years ago, and I wanted to hear what Laura Parnell had to say, and so did a week-long training with her, and I was really inspired that as I was listening to her recent version of EMDR, I wondered sometimes if she recognized how many people's work she incorporated. So I started writing down different people's work as she was talking. And this is the list that I came up with. And these are people that I think have influenced us over the last 30 years. There's probably a lot more, but it's just the beginning. And we'll be mentioning their names as we go along and can give you references later. But I realized that over the last 30 years, there's been so many gains in this field. It's just been on fire that a lot of times people don't know where their material is coming from and what's influenced them. And that it's likely that probably no two therapists do trauma work the same way. I guess no two therapists do therapy the same way. But I think when people say they do trauma therapy, I don't know if what they're doing actually has any consistency. So, using Lori and I as an example, I think Lori and I probably do trauma therapy differently too. So I may say something and she'll disagree with me and vice versa. And maybe that's constructive in some ways. But I think what we'll tell you is some of the lessons we've learned, some of the mistakes that we've made along the way, as well as, we probably have worked with more than 1,000 clients at this point, and try to see if we can tell you what we've learned from doing that work. We may not get through today. We're going to go 2 hours. And if we don't, we're not going to rush through this. We'll just continue next month and do part 2. But we're going to give you the luxury of a more depth approach. Now, our current evolution, just as a little background, is Lori and I ran Masters and Johnson trauma program 30 years ago. And in that, what originally happened was that Dr. Masters had written a grant on treating rape trauma. And we were looking to write down how to do therapy with rape. And if you look at the literature in the early 1970s, there's practically nothing on how to treat trauma. And so I went to the library and started reading. And the material there was really from World War I. And I was reading the World War I literature on how to treat PTSD and began to borrow from that to figure out a program to treat rape. But I think sometimes people forget how young this field is and how little we knew. At that time, really the only person's work who really was significant was Marty Horowitz. He wrote this book called Stress Response Syndromes, and it was a terrific book about grief and the stages of grief and the cycles of trauma. And that was what inspired us in the beginning. We've evolved over time. We ran an inpatient program in both New Orleans, Kansas City, Los Angeles, and St. Louis. And we eventually decided to move away from those inpatient programs. And in our second evolution, opened up a residential treatment center for eating disorders called Castlewood. We ran that for many years. And what we found was that a lot of people came through that program and then relapsed. We followed everybody up for a period of time to see our success and our failures and studied our failures closely, trying to understand more about what we were doing right and what we were doing wrong. It was an evolving field. And finally, in this third evolution, we decided that running an inpatient program or a residential program, people do really well while they're there, but oftentimes when they leave, it's too precipitous of a drop, and a lot of them relapse. So we decided that the next step for us was going to be a partial hospitalization program. And that partial hospitalization, we could do 6 hours a day of therapy, but then they went back to their homes or their life or their jobs or their school and began to have difficulties, so that it wasn't such a precipitous drop. So in our current evolution, we run partial hospitalization, and we allow people to live in one of our houses that they can begin to have some sort of if they're coming from outside the city or state, uh, uh, therapeutic community to be able to get support, particularly for eating disorder clients, for meals. So what we ended up doing was, since so many of our clients have comorbidity, we found that as one trauma manifestation in addiction would go down, like, for example, eating disorder, oftentimes alcohol or drugs would go up. So because there's so much comorbidity and so much co-addiction, we decided to run 5 separate tracks, one for trauma and PTSD, which we get a lot of military, one for mental health, depression, and bipolar, for acute depression and anxiety, one for eating disorders, for anorexia and bulimia,
and binge eating disorder,
and one for drug and alcohol, and one for sexual disorders. And so what we can do is we can have a therapeutic community of about 25 clients, and then have smaller groups which are targeted around each of these specific difficulties. So that's our present evolution, and we just sort of listed that here. Now, I want to evolve our thinking and just say that what we do now doesn't really resemble what we did then. And it's important to sort of note how this has evolved, because by the end of this talk, what we're doing is going to sound very different than where we started. Because at that time, I noticed that 90% of the women who were going into psychiatric hospitals had been sexually abused. And the current modality was, don't talk to them about the sexual abuse, because if they have borderline personality disorder, they'll end up regressing and become psychotic. And that there was not a lot of literature to support that, but there was always this idea of being cautious. And so I thought that was crazy, because if somebody presents finally with the courage to talk about the fact that they've been molested or raped, to tell them not to talk about it would seem re-victimizing. So what we decided to do was go the other direction and be able to say, we are going to treat sexual abuse and sexual trauma, and we're going to have the client talk about the trauma and attempt to resolve the trauma, and watch what happens. And Silk and several other people were noting that about 90% plus of clients who had borderline personality disorder had a history of sexual trauma. And so the hypothesis was that if the sexual trauma was resolved, then the borderline personality characteristics that you were measuring on the DIBR would decrease. So we gave that DIBR to all of our clients, and indeed we found that as we did the trauma work, which we'll talk about what that consisted of, that the borderline traits went down. And since borderline is an Axis 2 diagnosis, it shouldn't be that unbendable. So it was suggesting that a lot of what we were seeing was Axis 1 work, not Axis 2, and that it was highly amendable to trauma-based therapies. But we needed some documentation of that at that period of time. As the years have unfolded, more and more of a realization that what was called borderline personality at the time was very much overlapping with a history of not only PTSD trauma, but now we're calling complex trauma.
Yeah, all I would add to that is that people that were not in the field 33 or so years ago may not realize what a moratorium there was on even doing a history that allowed people to talk about traumatic things that had happened to them. And in that way, I think we've all come a long way.
As an example of that, in the textbook of psychiatry in those days, it was saying that 1 out of 1,000 women were sexually abused. And when the hotline started, it was found to be 1 out of 3 or 4. So, I mean, how could the field be that far off. And I think there was a kind of a cultural and professional denial of what was going on, across the board, that between our empirical data that has been collected and what you see on the slide, as well as hotlines, as well as the media, obviously this has been changed.
I think also it's a little bit different that Mark and I didn't actually come to the trauma field in the same way that many people did, and especially in terms of sexual trauma. Mark and I were working in the Masters and Johnson model of dealing with sexual dysfunction. So erectile dysfunction, this was before Viagra and all the other things, and anorgasmia, vaginismus, inhibited sexual desire, and things of that nature. And so we were accustomed to working with couples and looking at the intimacy in the relationship and the communication in the relationship and level of comfort with sexuality as a natural function, and sort of helping people become more robustly able to enjoy their intimacy and sexuality with one another in relationship. And so working with couples in that way, periodically, of course, there were people who had high level of trauma, and they weren't particularly helped. They were helped somewhat by a brief therapy focused on the relationship, but needed something additional. And that, at least for me, is what caused me to begin to attempt to figure out how to help those people that couldn't be helped in other ways. So we actually come to sexual trauma through thinking about healthy sexuality and what does it take for a person to have that and to re-own it when it's been taken from them or denied them by life events.
At that time, this new field was developing called Developmental Psychopathology. And it was a radical change from the current psychiatric model, which was one of putting people into diagnoses in a medical model kind of way. And it was suggesting that the roots of psychiatric disorders were not phenomenological, I just described the syndrome, but had a developmental basis to it. And that everything that happens to a person from birth onward can contribute to what we see as an adult psychiatric disorder. The journal Developmental Psychopathology was born. I got to each month, and the field was on fire. It was so much literature coming out. And so you had the experimental literature and the clinical literature, and the psychologist's approach to psychopathology began to radically change. And we're looking more at an ideologically based disorder. So PTSD, which later became a diagnosis, was divergent from so many of the other diagnoses in the sense that it was ideologically based, whereas none of the other diagnoses were. And as complex trauma eventually emerged, it became even more developmentally based, saying that living in a home where you're stressed out on a day-by-day basis in your own home 24/7 is going to result in changes in the brain that are quite radical. So interpersonal neurobiology was born at the same time. So developmental psychopathology and interpersonal neurobiology began to emerge. And for the first time, we began to see that psychiatric disturbances had a long history, and everything that happens to a person needs to be put into understanding how to change the adult psychopathology. And I remember at the time, I was doing an interview with somebody from the media, and they were saying, well, how can you have things in the first few years of life affect you if you don't remember them? So you go into a therapist's office and they say, what happened? And if you don't remember it, then it couldn't affect you. And I think that was a really fascinating statement. So I said to the person interviewing me, you think if a person was left in the crib for the first year of life that it wouldn't affect them and not touched or held? And they said, well, I never thought about that. So the question is, there are things that happen in these first few years of life that are radical. The mammals, of all mammals, the human is the least developed at birth. And so there's so much that occurs in those first few years of life. How does that happen before the cortex is even brought online? So it becomes interesting to begin to imagine sort of the physiological basis of this. So I came across this slide, and it was really memory bumps, which are dendritic spines, and each spine was less than a millionth of a meter, and that in those glutamate receptors are plentiful in these dendritic spines, and so there's kind of motor memory. So at that time, Bessel van der Kolk was writing about the body keeps the score, and that there was something happening in the limbic system where there was, implicit memory occurring in these early years of life, which were very different than declarative memory. And so the idea was, how does implicit memory affect people versus declarative memory? And that became part of the basis of trying to understand how trauma begins to work. But one had to first formulate sort of physiologically how that would occur in the brain. So you want to talk about this a little bit?
No, you go ahead.
Okay.
I'll just.
So, I'm jumping from years, obviously now we're jumping 20 years later, but, the thing that really, I think, blew everyone's mind was that in this study of adverse childhood experiences, 17,000 HMO memories, what was found was that 22% were sexually abused as children, and 66% experienced abuse, violence, and family strife. There was endemic levels of trauma occurring in the population. And the fact that it was done through a medical gave it certain credence. And then, I'm going to roll through these quickly, but if you notice that as the ACE scores, a person has more and more of these adverse childhood experiences, the higher the rate of adult depression. Next slide. And following that, there was an increased rate of suicide, increased rate of alcoholism. Now, in some ways, this changes everything, because what you're seeing is that what was thought of as, what was thought of as something that, a medical illness that a person has, medical model, we're beginning to see that these events that occur. Now, the thing about these adverse experiences is that they didn't necessarily mean PTSD. What it meant was somehow that the person had an overwhelming experience. And so more and more, the word trauma became a little bit more diffuse. When originally we were talking about trauma, we were talking about PTSD trauma. Now we're talking about the traumas that were not meeting the criteria of PTSD could have severe long-term effects. And in these long-term effects, that we had to begin to think in a more broad way about defining what is trauma. And it's fairly idiosyncratic. So an event such as a death can be very traumatic to a certain person who is highly susceptible. For example, a person who's quite sensitive, then and not traumatic to another person. So the criteria for trauma became a little bit more obscure. And that's why later, when they defined complex trauma, it was much very controversial, but also really important to begin to somehow recognize the developmental psychopathology of this. Now, this slide I want to show you now from Peter Fonagy is really one of the most important slides that I've ever seen, because what Fonagy and some of his associates looked at was early attachment style. And most of you know that attachment is measured in the first 18 months of life between the infant and the caretaker, and using the strange situation. And there are 4 different subsets of attachment. And what was so remarkable is that when he, in a psychiatric unit with a fairly large sample, what he measured was disorganized attachment. And what he found was that almost all the clients that presented with psychiatric disorder had disorganized attachment. Now, to me, this was a game changer, because what it meant was that instead of looking at the symptom, depression, anxiety, suicidality, eating disorder, alcohol addiction, even borderline personality disorder, or looking at bipolar disorder, that they all have one thing in common, which is that they have a history of disorganized attachment. And so Lori and I began to really want to understand attachment. So we went ahead and we got trained by Mary Main's people on the adult attachment interview. And that was a very rigorous kind of week-long training, 10 hours a day.
Yeah.
And it was so useful in our thinking because we suddenly began to look through the lens of attachment rather than just the lens of trauma. And when we did that, the question came, how can you take somebody who has disorganized attachment and move them to what we call earned secure attachment? And so my curiosity was, let's say we're treating eating disorder, which we were at the time primarily. The people who we were able to turn from anorexic and bulimic to eating in a healthy way, were they changing from disorganized attachment to earned secure attachment? And how do we make that change occur? And so that became something that we began to study. In that training, we got trained with Dan Brown out of Boston. And he was curious in the exact same way. And he eventually wrote this wonderful book on attachment, where he, like us, began to focus on how you move disorganized to secure attachment. And that has been incredibly useful to us in changing how we work with patients.
Mark's going to talk a little more about specifics and disorganized attachment. I want to put things in a little bit different framework that actually is the same as how I've always seen it. So I think over time, what we call things changes, and often from field to field even, there's a level of fragmentation in which things are called different things, which makes it somewhat confusing at moments rather than unifying, and makes one field's research not necessarily as accessible to other fields. And I think that people don't really know the level of segregation among fields that's been the case until more recently. So, but to get to the point of what I was wanting to convey, I've always seen it as the traumatic events that occur, the things that are too much for the person's resources, internal and external, at the time it happens, and so can't really be assimilated and worked through in any meaningful way. Those events to me are in the foreground. They're things that go on and happen at moments in time. But against that is the backdrop, and the backdrop is always the attachment environment of the person at the time of the trauma, and especially originally, because attachment classifications tend to be pretty robust in terms of being laid down very early in time and being consistent over time without intervention. And so I think that trauma can't be treated without understanding the environment in which it occurs. So, for example, Mark was saying that one person who's especially sensitive may be impacted by a death in a way that someone ostensibly less sensitive would not be. And I find that a bit of perhaps a misnomer, in that sensitive tends to be an attribution that was often stated to people when they were being not helped to deal with feelings. So someone just said, "Oh God, you're so sensitive." And so I shy away from that term because it's one that causes the person to blame themselves for not being able to get beyond certain experiences that reasonably enough for any human being, like mortality, are very hard to get through. And especially for a child who hasn't really been alive that long and doesn't have the frame of reference or the capacities or the neural pathways that they will have as an adult. So to me, what makes the differentiation is somewhat less of the child's sensitivity and more of the attachment environment's capacity and to meet the child where they are. And so with death, for example, I think a lot of adults have not really been able to deal with it, have not dealt with their own grief experiences in a way that allow them to help the child come to some safety in a world where there's been a sudden death of someone loved. And the child thinks, how in the world will I be safe again? They may not think it that way, but they're striving to try to find safety. And when there is no reestablishment of safety, when there is not the ability to entertain the child's various feelings, especially the most intense ones, like grief, then it becomes problematic. It's not anyone's fault, because I think people tend to focus too much on who should we blame for this, because often the parents themselves haven't been dealt with in a way growing up that would allow them to be any better at helping that child than what they can muster. But nonetheless, something that might have been able to be bounced back from becomes something that just tends to be kind of a black hole within the client and never really dealt with, so that when more and more grief and loss occurs over the lifetime, it activates some of the original terror in ways that the person is unable to fully assimilate or understand, not realizing that it's not just about the current loss, it's about all of the unprocessed loss as well up until that point.
All right, so what I want to do next is talk about disorganized attachment, because my goal is to convince you that one of the key elements that we're going to end up on is that perhaps one of the biggest problems, I think, in doing trauma therapy is that people have not been well enough trained in working with dissociative features of it. And that because of disorganized attachment, one of the things that Schroff found in his longitudinal research on attachment was that the long-term effect of disorganized attachment was adult dissociative disorder. And the importance of that is that with trauma comes dissociation, and with dissociation comes fragmentation of the self system. So when I began to do the work on that, I went back and I read Kohut and Winnicott from start to finish, and I realized that self psychology was really, long ago, right at the very core of trauma work. And so then I went back and I read Pierre Janet, and I realized that at 1900 we knew much more about dissociation than we do now. And most professionals hadn't been trained in that. So they were saying, I've never seen a client with dissociative disorder. And it was really that they had never really been trained to diagnose it. So people like Jean Briere, who began to develop the TSI, Trauma Symptom Inventory, and Frank Putnam, who did the DES, really helped us begin to operationalize what dissociation is and how to measure it and how to begin to look at the subsets of that. Because it turns out that most of the clients that we see have an impaired sense of self, and they really don't know who they are, and they feel lost. And the part of the reason is because we hadn't conceptualized developmentally what happens at various stages of development. So if you have neglect in your life, there are certain things that you're not going to learn how to do in terms of being able to be with people or to be able to live in the world. And so eventually that was called metacognition. And there began to be much more research in metacognition at people's knowing how to know. And varieties of scales came out in metacognition. And, people at Menninger worked with Fonagy with beginning to talk about metacognitional therapy. And metacognitional therapy was really dissociatively based. So that was another whole way of coming at it. Peter Fonagy is a genius, and he really developed how to be able to approach this from an analytic standpoint. Now, as you sort of decontextualize this a little bit, what you see is that what disorganized attachment is, it's an affect dysregulation problem, i.e. you can begin to think of Marshall Linehan's work with affect dysregulation, lapses in self-monitoring. And what happens is the client would come in, and if you would do trauma work, they would get somewhat better, but it wasn't necessary. It was necessary but not sufficient. So I would go back to Bessel van der Kolk and I would say, yes, we can treat PTSD effectively, but that doesn't mean that the client is effectively treated. What we need is to delineate that PTSD treatment is necessary but not sufficient. And what are the other components of working with trauma other than trauma resolution? And a lot of it has to do with the development of the self system, integrating parts of self that are discontinuous, that are part of this disorganized attachment. So it gave us a lens to set new goals in trauma work. Clients would come in and we would do trauma resolution therapy and they would get better, but they left and they had impaired self-agency and they had never learned how to be able to explore their environment and learn how to play and have fun. And so I remember one client came in and she was anorexic, she was dying. I worked with the anorexic almost textbook-wise with family therapy, did really good work and reversed it, did a lot of work around her childhood trauma, did trauma resolution therapy effectively. And she said to me as she discharged, Mark, I don't know how to live in the world. And I said, well, what do you mean? And she said, well, I can't write checks. I can't pay my bills. I don't know how to be with people. And I said, well, I can teach you how to do that. And she said, you don't get it and you never will. And that really kind of hit me hard. And about a month later, we did follow up with her and I sent one of the staff. And in her room that she was living in, it was filled with beer cans and she hadn't left for weeks. And, she had been deteriorating slowly. And she was just terrified to interact with the real world. She had been enmeshed with a mother for so long that there were so many things she didn't know how to be able to do. And I realized that something was missing. So I went back and I began to study Stanley Greenspan. And he wrote this book called Structurally Based Psychotherapy, Developmentally Based Psychotherapy. And what he said was that there are structural deficits that children get when they're not given adequate parenting. And so I realized that instead of trauma in the traditional sense, we had to look at neglect and what developmental deficits were there due to neglect. And that these interventions could not be reversed through cognitive behavioral therapy, that teaching people the skills was not going to work. I tried it and it didn't work. And so the question is, how does one give these structural abilities to people when they miss them developmentally? First, it had to be delineated what they were. So as you look at some of these, you just get to see dissociative parts, inhibited exploratory behavior, controlling versus submissive responses to their environment, so on. So what I wanted to look at metacognitionally what was going on and behaviorally what was going on, identify these deficits, and then measure them so that I can then set goals for the client and say, this client has difficulty with interpersonal interaction. This person's flooded with anxiety because they're so disorganized inside. This client is very, very depressed because they have no self-efficacy, and begin to have more robust goals in working with the trauma client. Now, at the same time, obviously, huge numbers of people were developing in the field. And of all the people that blew me out of the water at the time, Janina Fisher, she was working with Bessel van der Kolk at the time, and I heard her lecture, and my breath was taken away because her ability to conceptualize was incredible. And she was saying so many of the things that I was learning from my clients so articulately. And this is one of her slides, and she said, start with the assumption that every symptom is a valuable piece of data, and follow that symptom back and ask, how would this symptom have helped you survive in an unsafe world? So it was a reframe. Symptoms, depression, anxiety, anorexia, bulimia, alcohol abuse, drug abuse, these symptoms are survival strategies that once helped you survive, but now are interfering with your living in the world. And even something like chronic suicidality, that she reframed these as ways that you once learned how to survive. And the idea in this approach, which we were evolving and she was evolving at the same time, is that you wanted to be able to look at the symptom as a door or a window, or what Dick Schwartz eventually called a trailhead. And that if you look below the symptom, you can begin to understand its function and purpose. And I had this idea that every symptom has about 10 functions. And if we didn't try to not understand the 10 functions of the symptom and help the person find a healthy way to meet those needs, that we couldn't reverse the symptom. So our clients were coming in with multiple addictions. It was sex addiction, eating disorder, alcohol. But underneath that was the trauma, and the field was focusing on the symptom, i.e. 12-step work, cognitive behavioral work, and removing the symptom. And removing the symptom was a problem because the symptom was a clue to the underlying difficulty. And so what we wanted to do is to understand that you need to have this symptom until we understand its function and purpose. And if you remove the symptom, oftentimes you get symptom substitution. And the client doesn't get better, they just improve. And to really help them get better, you have to understand what's underneath it in some depth kind of way.
Well, I would say it's not necessarily so much predicated on understanding it as being able to allow for that function being met in alternative ways. So a person could happen upon that accidentally without even understanding the original function. But I think usually it's incredibly helpful for people to put in context why their coping strategies would have made perfect sense in the context in which they developed. And just, I'd like to give a couple of examples of this just so it makes sense to people in a more subjective way. So, for example, let's say you're 15 and you're living in a home where there's chronic conflict and the conflict flows over onto you. And so you go to your room a lot and just isolate. And because the family's caught up in chronic conflict, things are not happening that you really need in order to adapt to all of the changes that adolescence brings. So there are things that you're getting that are overwhelming and things you're not getting that are really crucial, but you don't even know what they are because they've never been available. You just feel more and more like an outcast, like you'll never really fit in with society. And so then things continue to happen that add to that sense over time. And let's say on top of that, you're expected to perform at a certain level that is either within or beyond your capacity, but it becomes harder and harder to do that. And even if you can do it, you feel that your value is tied up in producing rather than any innate value. And so, the environment is not necessarily able to be nourishing in that way. And so self-harm becomes some way of coping with feelings that there's no other way to cope with. And self-harm seems like a bizarre symptom to a lot of people, but it almost becomes a friend, a go-to. Or let's say you are living in a household where you feel you have absolutely no boundaries and that everything is prescribed by other people and you're not allowed to individuate and differentiate. And an eating disorder can become your way of insisting on boundaries that are hard for someone to argue with. And it's as though the eating disorder can become, your anorexia can become what feels like to the person a refuge in which they can be themselves, which again would seem like a very strange way of having identity, except not necessarily to the person who's reaching or a person, for example, feels incredibly socially awkward, and perhaps the family themselves are really unable to help the child develop social skills and to provide opportunities for the child to address their social anxiety. So the child retreats into video games or some solitary activity, and then they have to go to something and there's alcohol, and they drink alcohol, and finally they feel, oh, people like me. I'm able to interact. Wow, I don't have the anxiety I have every minute of every day when I go to school or when forced to interact with other humans. So all of these things have a function in the original context. And the problem is that in the later context, what absolutely might have saved a person's life can become the very thing that threatens their life.
Now, Dick Schwartz, later in internal family systems therapy, came up with an ingenious sort of way of going at this. He would say to the client, what are you afraid would happen if you let go of that symptom? And when I asked that question, the first 20 people I asked all gave the same answer, which was, I'm afraid I'll be alone. And so it brought me back to the attachment literature of realizing that since they had disorganized attachment, somehow the symptom had a primary function of dealing with their feelings and terror of being alone, and numbed it and modulated it, because the disorder was a disorder of allowing oneself to be loved. They could have relationships, but they didn't feel connected. I remember one client who came in, she was incredibly charismatic. Everybody wanted to be her friend. And I thought, wow, this person's pretty well differentiated. And in follow-up, I met with her, and she gave me the history that she was completely alone and had no connections. She said, while I was in your program, I know it looked like I had a lot of friends, but the truth is I felt alone even when I was with people. And it again taught me that what we are observing in people's behavior may not match internally their experience, and that at its very core, if we didn't do something about helping a person be able to receive love or receive connection, that they're going to go back to their symptom. And so, when I use the word intimacy disorder, what I'm talking about is the person's inability to receive connection. And it's sort of like in the old days, I was working in endocrinology. A hormone would be in the body, but it wouldn't bind to the receptor site. And it felt a lot like that to me, that person was with people, but they couldn't connect to the person and feel safe in that way. And that is at the very core of disorganized attachment. So to me, when I'm looking for treatment success, what I want to find out is the person has the capacity to form interpersonal relations. And that's a really big field all by itself. So Mary Harvey is another one of my heroes. And she's out of Boston. And she sort of summarizes this in this slide. And as I began to decontextualize in my mind sort of what I'm talking about here in terms of developmental disorders, I identified each one of these pieces and tried to begin to figure out how to be able to measure them. And as we talk about structural deficits, some people literally can't take care of themselves. And that's a huge deficit. And Judith Herman realized that in her original book, that self-care was like the very first thing you had to be able to deal with individuals: eating, sleeping, exercising, and the basics. And then cognitive schemas, that there was nobody more on target than Jeffrey Young. And we went to some training from him. And what he was saying was that these schemas are not amenable to cognitive-based therapies, that one has to figure out how to get into the hard drive of the brain and change these early schemas that are based in the disorganized attachment. And so schema therapy became incredibly useful in beginning to think about how you change these core schemas, because you have to think of these as imprinted into the brain, interpersonal neurobiology coming back again. And so it's like cognitive behavioral therapies were useful, but oftentimes insufficient in being able to work with this in varieties of ways. And so on down the line. I'm not going to go through all of these, but if you can look at any one of them in terms of what you're working with the client.
Well, I think actually good cognitive therapy is a bit of a double-edged sword, because it's absolutely essential. And looking at belief systems and looking at the attributions they're based on, perhaps, and beginning to be mindful about them, or in other modalities, beginning to challenge them, beginning to reality test them to see, are they accurate in the here and now? It's useful, but I think sometimes people then feel like, well, I know better, so why the hell do I still act as if I'm operating under what I came to believe as a child, even when in my adult self, at my most lucid moments, I know better. And they feel as though somehow it's, again, some deficit in themselves that doesn't allow them to avail themselves of fully integrating the new information. But as Mark's discussing, sometimes these things exist internally in ways that are not readily accessible to simply the cognitive portions of the mind.
So what evolved was a new lens, which Diana Fosha popularized, I think, in her affect-based psychotherapy. Bessel was talking about at the same time, and large numbers of other folks. And the realization that so many of these deficits are written into the lower parts of the brain, the limbic structures, and that the window into the limbic structures was going to be affect. And so the goal was, how do you access intense affect in a 50-minute hour, and to begin to structurally change what was in state-dependent memory. And so more and more research was beginning to look at implicit versus explicit memory, and to look at the very basis of what was written in implicit or even unconscious processes, and that how affect-based therapies. And so hypnosis at that time was popular. EMDR eventually evolved, internal family systems, affect accelerated psychotherapy, schema therapy, tapping, a whole variety of psychotherapies focusing, began to recognize that if you were going to do cognitive-based work, it had to be in a strong affective state. And so the basis of trauma therapy is not so much working on resolving memory, but more on taking the lens of looking at the present symptomatology and understanding how it got engraved into the limbic structures as a survival strategy. So in those days, what we wanted to do was basically derive from the training in hypnosis, which was affect bridges. If you follow affect back, oftentimes it leads you directly to where it needs to go. And so, the client would come in and there would be these symptoms that would be highly emotional. And if you just follow those emotions back, oftentimes they would take you right to where you need to go. So a simple procedure, which we began to use, 30 years ago, was scanning.
Yeah, I think it's just to say, if someone's out of control of affect, what you do is stabilization. But then when there is some stabilization, you can, allow the person to scan back, is how we used to do it, from the current feeling or the current somatic experience or the current cognitive questioning about something. And scanning was a way in which a person could sort of, rifle through the file cabinet of something and pick out like files that had something to do with that particular thing. What it tended to provide was awareness of what all went into the file. It didn't tend to provide new information, but it provided information that by virtue of coming up in the context of what was being followed, helped to shed some light on what things may have contributed to whatever the client was attempting to get more of a understanding of and to feel less out of control regarding. What I found with it is that it did provide cognitive information. It didn't really cause the client to feel a whole lot of affect, though. And so preliminarily, it could be useful, but there was still going to be the necessity of assisting the client to deal with the cognitive affective state in a more integrated way so that things felt resolved, not just awareness being expanded.
So just again, to flesh this out a little bit, there was a client that I worked with years ago, and he would have compulsive sexual behavior with men and then come back home to his wife and kids. And we might have what he called 10 tricks in an evening. And at that time, HIV was very virulent, and he was going to kill himself and his family. And he would describe that when he had these tricks, he would have what are called butterflies in his stomach. And so I just had him imagine the butterflies in his stomach and then follow them back. And it took him back to when his dad was sexually abusing him. He would experience butterflies in his stomach. So there was something in the reenactment and repetition that was tied to that in some way. And so we were accessing implicit memory. And as he tied together the current with the past, it began to, instead of eliciting a feeling of safety, instead terror. So the terror and the experience of the tricking got tied together. And at that point, he was able to stop, and it worked like a relapse prevention technique. Now, it didn't cure him, but it allowed me to get some relief from the symptom long enough to begin to do more of the work around the sexual abuse.
Yeah, I was also thinking of an example on the way in this morning of how scanning was useful. So when you have a recalcitrant symptom that the clients tried to go at from a variety of different modalities, this wound up being somewhat useful back when. I think there is an even more useful way currently, but so I was thinking of the example of the client we had, and he had a particular fetish sexually, and he was in a relationship with a partner, and the fetish really came between him and being able to feel connected with the partner. And he didn't want to be at the mercy of it, but he couldn't really put together why he would have such a symptom and felt just pretty much shame at not being able to relinquish it. And when we were able to do scanning with him, he connected with a memory that he'd always had, but had never really talked about. Because the worst things that happen to us, we, I think, all want to put in a box, lock it up, and put it in the basement of our awareness and move forward like society tells you. Just move on from that. The problem is those things in what seem like those airtight boxes don't discontinue to impact us, but they just impact us often in ways that we're not aware of the connection of, and therefore we feel perhaps more screwed up than ever, not being able to understand how in the world would I be doing such a thing. So in his case, it really, the scanning was able to allow him to talk about and feel about as well this chronic bullying that he had in high school, which he always knew about, but he got in touch with the specifics around a particular locker room incident with the other boys, in which actually what it was that he now did as part of his eroticism was done to him as part of his humiliation. And he never put the two together prior. So it's not as though it were something new, but it's something that he had never really allowed himself to deal with subsequently for reasons that are reasonable. And he was really able to go back and and ultimately to be with himself from his current capacities in a way that actually that adolescent boy had really crucially needed someone to be with them, but there was no one to turn to for him at that point in his life. So a lot of what winds up being healing, actually, just to venture off into this, is the client's ability to reparent themselves in a way and to provide whatever was not originally available. But to do that is very difficult originally for most people because they associate those aspects of themselves with the things that happened. And so they feel a sense of desire never to connect with those parts of themselves, and also often blame those parts of themselves for the trauma, blaming the victim, really.
So 30 years ago, the model that Horowitz suggested was abreaction, particularly with sexual abuse survivors, which was a revivification of past memory to rework the trauma. And in truth, that probably was the wrong model. And at the time, I think that there was a kind of an emphasis on not talking about trauma. And so there was this idea that, look, when you have something like grief, one of the most useful things is to be able to find a family of choice and be able to talk about it with other people. And if by doing that, you can eventually get to the other side and with the right comfort and soothing, eventually work through the grief. And that alienating and isolating yourself was probably antithetical to grief resolution. And trauma is really a grief model. The problem with that is that more and more data began to be accumulated saying that for some people, talking about trauma can make it worse and they don't get to the other side of it. So one of the burning questions came, what kind of work do you do with memories? And is memory work really trauma work? And so I think that still is an important issue in the field, because I think some people think that trauma work is having people talk about memories. And so probably some attention needs to be placed upon how that model has changed and evolved over time.
Well, just to put it a bit differently, let me think about it, put it differently. Some people as therapists are themselves somewhat affect phobic. So it's very hard for them to tolerate a client's intense feelings. And often that winds up being similar to what given clients may have experienced growing up, where someone really could not tolerate their intense feelings and sent them to their room. So clients learn to read signals, especially clients who've been through traumatic experiences. They become so highly attuned to other people that they perceive nuances and subtleties that often the average person might not. And so when a therapy is such that the feelings that come up for the client can't be permitted, it's a problematic therapy that doesn't truly resolve much. On the other hand, there could be therapists who would find it somehow consistent with their own temperament to allow lots of affect. And what I would say is that there's some clients who feel in a way that actually blocks feeling. So too little feeling and too much feeling block actually getting in touch with the cognitions and the affect in a way that can be healing. So I recall one I had a client come in and she said, I have gestalted my father and psychodramatized my father to death. And I've done this and done that and felt this and felt that. And, and she was actually hardly finished. She actually didn't seem to have begun because she was very good at feeling. but the way in which she was feeling actually blocked her getting in touch with what it actually felt like when the dilemmas were creating themselves earlier in life, and blocked her ability to have compassion for the earlier versions of herself. So it looked like a lot was going on, but not much was truly getting assimilated or unburdened or integrated.
All right. So at the cornerstone of trauma treatment has been the telling of a story to a witness. And the idea of this is that humans really want to be heard and want somebody to do something to shift their state. So wanting to be heard is important. So for us, group therapy has always been a treatment of choice, because being able to talk out loud about what happened to you and having a village of people to hold you and nurture you and care about you and support you is really critical. So we've always tried to work in a residential setting because it provides for the building of a therapeutic community. And whenever we try to do this work outpatient and we have groups, it can provide very similar. But the more effective the community is, the more healing it can potentially be.
So to say that in a little bit different way, one of the qualities of our most painful experiences, which I'm not going to call trauma because I think that's too reductionistic, but the things that we can't let ourselves feel, the things that we can't reconcile, the things that we can't figure out, the things that we can't move past, the things that keep reasserting themselves in our lives in the same form but in slightly veiled ways, those things, usually when we've experienced those things, what we felt at the time is alone and uniquely screwed up, to use a non-clinical term. And I think that the reason that group therapy, when it's powerful and where the group norms support people disclosing things in ways that are incremental, is that what can happen is other people in the group say, I didn't have that experience, but here's how I can relate to it. And then people feel less alone in their aloneness because they realize that, you know, in many places in the world, when they were feeling their aloneness, were these other people that they've learned to care about and value, who are feeling the same feelings. And it's somewhat shame neutralizing, actually, in a powerful way, that one-to-one therapy between a therapist and a client can't quite measure up to. It's incredibly powerful. And so that's why we've always appreciated being able to have group formats as well as individual therapy formats.
So our next step in our own evolution was that we began to borrow from the Golding's model called reliving, revising, and revisiting. And the idea was talking about trauma could be useful, but there had to be some ability to not just talk about how you feel, but actually to experience the feelings. And so the idea was to have one foot in the past and one foot in the present, where the person could use their adult capacities to help integrate their childhood experiences. And so we were facilitating what Dick Schwartz later called self-healing. The therapist was a catalyst to self-healing. And the idea was the adult self, now older, bigger, wiser, and less dependent upon the family of origin, could begin to help that injured child or injured adolescent begin to assimilate and accommodate to the experiences that were occurring and move state-dependent memory from amygdala kind of storage to hippocampal kind of storage. And people like Marilyn Courtois and people out of Bessel's unit were beginning to document that you could actually see on PET scans as people assimilated trauma appropriately, actual changes in the brain that were occurring. In the sense, the amygdala no longer lit up, and the hippocampus did light up as you transferred it. So you had an interpersonal neurological basis for what you were observing. And the idea is that if it didn't move into the hippocampal until terms of long-term memory, that it still provided sort of indigestion and continued to cause psychiatric symptomatology. So at least we had a metaphor of what might be happening in the brain as you began to allow the person to experience and re-experience what happened to them, this time with the resources to be able to assimilate it.
Just to throw in another element, often, I guess for any of us really, but especially in experiences that feel highly traumatic and or highly alienating, where one feels absolutely alone, the wish is for a rescuer, which is absolutely normal. And I think the problem with it becomes that it continues to reenact itself. So people either become the rescuer they wish they had and go into a profession like, well, therapy, nursing, teaching. Not that all teachers or therapists or nurses have this as the reason, and not that many people in those professions didn't start out there and become more healed around their own experience in a way that really informed their ability to help others. But just saying, sometimes people become the savior they needed, and the problem is they give it to everyone else in the world except the parts of themselves that are desperately still in need of it. So, or they treat their children differently than they were treated. They swear, I'll never do what was done to me, and they're actually able not to do what was done to them. However, that doesn't heal the internal damage from what happened to them. And that's the hardest thing to deal with. Other people go out looking for a savior, and sometimes the transference is with a spouse or partner. And often people get together in a way where someone who learned to save everyone else comes together with someone who needs a savior, and that keeps each of them from being able to access what's necessary to heal. Not that it's a bad coming together. If both people are willing to grow, it actually can be useful. But if only one person's able to look at things or willing to look at things, then typically they're destined to recreate the very thing that will have them believing that they were right in the first place, that it's a hopeless situation and they'll never get what they need from anyone. So this desire for rescue, I think also it's what happens with therapists, that sometimes as a therapist, you actually want to give a person what they've desperately needed. However, that can be a starting point when it's boundaried in appropriate ways. However, ultimately, the person has to begin to be able to actually receive what they're getting, because sometimes it's as though, a feast is spread before a person in life, but they can't perceive it right in front of themselves, because even though things have changed, the internal apparatus for receiving it is still deflecting it because of not feeling deserving. So these are some of the elements that become important to deal with, because sometimes even when a person's life has changed dramatically and they've been able to climb out of whatever was traumatic or painful or stuck, they're still unable to take in the things that would make life worth living. And that is a pretty normative aspect that sometimes is not dealt with as directly as it perhaps needs to be.
Okay, just to anchor us, we're still 30 years back. And where we're heading is we're trying to show you how we evolved over a period of time and how the field has evolved with us. So the next step in our own evolution was Pat Resick, and she was in St. Louis at the time. And she was developing her information reprocessing model. And it was complementary to Edna Foa's model of exposure therapy. And in these models, the idea was the realization that what was important was not so much dealing with memory, but dealing with the cognitions that were embedded as a result of the trauma, and that the strong affective responses. And so in Pat Resick's model was cognitive reprocessing. You had the person recall the event and look at how it influenced it influenced their sense of self, how it influenced their perception of others and the world around them. Now think about that. How it influenced their sense of self, influenced their sense of others, and the world around them. And so it brought the focus to how the trauma is affecting you in the here and now, as opposed to the then and there. And that focus was a shift for the field, at least for some people in the field. And then what she said was that there are stuck points that keep a person from being able to integrate the cognition, the affect, and the soma. So there's a somatic component, there's an emotional component, and there's a cognitive component, and that integrating the three of them was going to be critical. That was terrific. And so the idea then became that processing a memory allows the person to digest that. Now, there are different ways of going about that, but it turns out that EMDR, which was evolving at a similar time, was really a beautiful way of not leading the client, but letting them. So you would start with the here and now. Tell me a little bit about what you want to work on today. And you might say, I want to work on my compulsive eating. And then you would begin to do EMDR, and you would see what Francine Shapiro would call the channels of trauma that somehow flow into that symptom. And so there would be one channel, and then underneath it was a second channel, underneath it was a third channel. And you wouldn't be able to help resolve the trauma until you emptied out the three channels. It was sort of a hydraulic model. And what that brought in was Bowlby's original concept that the trauma is organized in the early attachment environment. And your adult response to trauma has to do with the original attachment environment. And so the stress response cycle is structured in a early environmental structure. And so the way, let's say you take 100 people in the front line of Vietnam and have a similar kind of traumatic experience, maybe only 4 or 5 of them would develop PTSD. And the question is, what is it that's unique about those 4 or 5 people? And I think in time, what began to be isolated is that they oftentimes had a history of developmental trauma and even childhood sexual abuse in a number of the cases. And so what would happen is that the ability to respond to adult trauma was somehow tied to the lack of resolution of childhood trauma.
Which makes sense in a variety of ways, because one thing that I was thinking while you were describing it is that actually Pat's model deals with the same things that you're actually dealing with secure versus insecure attachment. So children that are securely attached have a more integrated sense of self as deserving and of others as available, and of the world as a place where their needs could be responded to. That's like a really big deal. And that really is the essence of secure attachment if you want to boil it down. So then, if a person's already not securely attached, then when things happen, the attributions they make about what's happened are consistent with attachment. So for example, when you're a child, children often think that so many things are about them because we're kind of the center of our universe as children, and we don't know the limits of our capacities. So, for example, if mommy and daddy argue all the time, we think if we were a better child, maybe they wouldn't. And these types of things, we think if we were often more of something or less of something else. So often, a key idea really throughout various syndromes is the sense of feeling like you are too much or you're not enough. And so what happens is, at some level with trauma resolution, it seems to me that you're changing the ability to affect regulate, right? So that things are not so overwhelming that they can't be processed and integrated. But you're also changing the belief systems, because one reason things can't be integrated is that things exist internally in compartments that allow a child to preserve, typically at the time, their sense of hope. For example, if it's about you as the child and you could just do some more of something or less of something else or be a different kind of child, then you have hope that things would be different and there would be improvement, and you could, everyone would be happy and get along. And so in that childlike kind of a way, you learn to attribute undue influence to yourself, when in reality, you aren't the one making the rules as a 5-year-old, 6-year-old, 8-year-old, 10-year-old. And so yielding up that sense that it was about you and your deficits to look at what were actually the capacities and the deficiencies of the attachment environment for whatever reasons is really important, but a very hard thing to do, because it feels as though it can feel as though originally something's being taken away and not replaced with a connection that is durable.
Okay, so this model became necessary but not sufficient in my mind. So I do a cognitive reprocessing group every week, and I start with cognitive reprocessing as a first stage of being able to do the work. And at the same time, I began to work with EMDR, and Francine Shapiro, did the thing, and I kept doing it. Some of the clients got better, but a lot of them didn't, and they get caught in these sort of webs. And so I kind of abandoned it over time. And what I realized is that there was this whole new epidemic of therapists who were doing trauma work because they had taken a 2-day course in EMDR. And that always scared me a little bit, because doing EMDR is not trauma work. It's a tool for doing trauma work. And so over time, what I had to do was integrate what I had learned from my trauma work into the EMDR. And that's why, as the field has evolved, EMDR now is not like it was 20 years ago. And what the key feature became what was called the cognitive interweave. And as we became more sophisticated with the cognitive interweave, really skilled therapists could make EMDR into magic. And lots of good things happen. And when I see really good EMDR therapists, they're able to do really fancy cognitive interweaves. And that's what Laura Parnell was teaching, was she was integrating all these people's work into the cognitive interweave. So my point is that talking about trauma doesn't necessarily make one better. Affectively re-experiencing the trauma doesn't make something better. It's beginning to rework the schema that are embedded into the trauma and the state-dependent memory that then can begin to change the person's thoughts, feelings, and behavior in the present. And that's what we're going to begin to focus on more.
So in a very simplified way, resolving trauma and being able to move forward into a life worth living really contains the components of affect and what's necessary ultimately to allow for affect regulation, not by only learning tools for affect regulation, but because of being able to literally unload the charge of prior things that keep getting tapped into in ways that cause a person to feel out of control and to not be able to use the tools that they can use perhaps the majority of the time. 2, it's about cognitive questioning and restructuring to be more in line with reality, as opposed to what you might have thought originally when it happened, which usually involves high levels of self-blame. And then 3, behavior, changing behavior. And I think it's absolutely possible to work on and necessary to work on all those at one time, as well as incrementally.
Now, of this Pat Resick model, she had this concept called stuck points. And I've always found this the most useful because, what therapy is usually used to dealing with is resistance and sabotage. And these stuck points then help the person look at their resistance and sabotage. And of these 11 criteria, the one that really I found most important was number 8, which is how am I still protecting those who hurt me? Because in the attachment literature, what we learned in the adult attachment interview was that one of the most interfering accommodations was loyalty to the family. And people who put up tremendous defenses. Well, my parents locked me in closets and burned me with cigarettes, but they did the best they could. And it's that loyalty was the biggest defense. Beginning to break through that in some way was really essential. So you were trying not to blame the parents, but instead begin to help the person look at the events of their life without rose-colored glasses in an objective way. And so a lot of the reconstruction work in developmental psychopathology is being able to talk to the mother, the father, the brother, the sister, the aunt, the uncle. And so what I began to do was to develop more of a systemic model. And I want to be able to look at the elephant from many, many different lenses. So whatever the person was telling me was going to be their perception, their brother and sisters would be a different perception, their aunts and uncles would be a final perception, and I would talk to anybody who would talk to me because I was trying in reconstructive work to take as many pieces of the puzzle and put them together, which I eventually called integration. And integration was kind of develop a coherent narrative of the actual events that occurred in a person's life and their perception of those events and the feelings associated with them. And there was something in reintegrating these pieces of the puzzle that was incredibly ameliorative.
Okay, wait, I remembered what I was going to say. Sorry, I just turned 60. I'm trying to integrate that into life. So in any event, just to clarify, loyalty to the family at the expense of self-acceptance and differentiation of the self. That's the kind of loyalty that we're talking about, where a person still idealizes and makes not human, but iconic attachment figures. And so the goal is to really to understand one's attachment environment and the attachment figures who are part of it as human beings, who have their capacities and who have their deficits, and who come into the situation of the attachment environment with those things, so that everything that happens is not just the result of the child, it's the result of the interaction and what has been often unfinished in past generations. Again, not because someone's at fault, but often because of circumstances that are actually somewhat beyond someone's control, going intergenerationally. But to be able to see that in context is, again, incredibly helpful in terms of neutralizing the tendency for massive self-blame while holding everyone else aloft and for tremendous shame. It really helps to neutralize it. And people are afraid, like, well, I have to be angry, at my parents. It's like, I don't know what you'll feel. You probably need to be open to feeling whatever you feel. And I think one of the most common ways it's stated, this loyalty, is people come in and they say, I've forgiven them. This happened and this happened and this happened, and this person was a tyrant and it had to be their way or the highway and this and that, but I've forgiven them. So in this case, it's not that forgiveness itself is necessarily bad, but forgiveness as a bypass so that one doesn't have to feel the feelings associated with the things that happen doesn't result in resolution. And so it's really about being open, as Mark said, to look at things with all of the information. I think of a couple of examples of that recently, which is, sometimes people's families don't want to come in because they imagine that, everybody's sitting around in a group blaming them and that they're going to come into, something terrible, which typically in reality is so the antithesis of what's happening. Most people would much rather blame themselves that I've worked with over the last 33 years than anyone else. Of course, occasionally you get someone in a victim role and they'd rather blame everyone else rather than take self-responsibility. That is very rare in my experience and with the populations that we work with. So recently, a couple of people's fathers came in and were willing to have family sessions who previously in other psychotherapeutic formats in the past, they didn't want to come in. They live out of town. They didn't want to come in. They found a reason not to. But in each of these cases, to actually have that parent present was so incredibly useful because you can see how not just you, but the client themselves can see, oh, my parent actually has a very significant, never treated, never medicated, never addressed anxiety disorder. And it's like, it's not subtle. It's like pervasive and noticeable. But when a person is around people for the entirety of their life, they just think, well, that's how so-and-so is. And they don't think about diagnostic categories, which is probably a good thing. But later in life, it really helps to understand other people have things that, by virtue of not addressing, filter down. And again, maybe they don't have the resources to address it, internal or external. But, another thing is a lot of times people will say, well, something like, my mother doesn't believe in mental health. Your mother doesn't believe in mental health? What does that exactly mean? And so I just want to reference the literature that exists that indicates that in the adult attachment interview, there's a category called unresolved for trauma. And there seems to be a correlation of adults being unresolved for trauma that then creates or is correlated with insecure attachment in the offspring. Whereas it doesn't seem to be that the amount of trauma, for example, a parent has had, is what is impactful about their ability to engender secure attachment in their children. It's the amount of unresolved trauma. So I think a lot of times what children and later adult children really long for is for other people in the attachment environment to have gotten help for the things that would then take the sole responsibility for change off of them. Now, you can't wait for that to happen because sometimes it's not going to happen. But we've also had examples where people come in for treatment, their parents come in to help work with the issues, and the parents are really open to looking at themselves and their behavior and their unresolved issues. And then we've had a few instances where, the client will say, after I'm not here anymore, it'd be really great if you came in because you had a harder childhood than I even had and no time to resolve anything. And you deserve the chance to have a better life than you've had. And it's just been amazing to me when that's able to happen. how much healing there can be throughout a family system. But it takes courage.
The next piece of this was that three fields began to merge. You had all the war trauma that was occurring from Iraq and Afghanistan. You had critical incident debriefing that would come from the horrors of 9/11 and subsequent. And then you had domestic trauma, the realization of the endemic levels of people hurting people in our own culture and other cultures. And the Society for Traumatic Stress Studies began to bring these people together so that they could begin to talk and realize that the fields needed to merge and that we needed to learn from one another. And so in this example of stuck points, we began to work much more with vets. And the idea with vets was that you would do the work around the deployment trauma, which was huge. You had the inescapable stress that came from this new war of you feeling like you can be destroyed at any minute, even in your sleep, rather than in the front line. And then you had the developmental trauma where so many of these people volunteered to go to war because their home environment was intolerable to them, or they had dropped out of school and because they were teased and couldn't pay attention from ADHD or attention deficit kinds of problems. So you had the very complicated picture there. And the critical incident debriefing people were realizing that talking and talking and talking about the trauma may not actually be useful for some people. So who is it useful for and when? The PTSD people were realizing that there are these stuck points. And oftentimes people in war would talk and talk about the trauma and just make themselves worse and the people around them worse. And so these fields had to begin to emerge. And so Pat Resick's idea of stuck points was really useful because it helped people look at where they get stuck in the trauma and how they're blaming themselves. And if you think of a grief model, usually, people are in denial or people are, what gets them stuck in a grief model is self-blame and feeling like they have some sense of control by blaming themselves. And so how to begin to unblock that stuck point became really critical. And if you think of the cognitions that are impairing the person from moving through the stress response cycle that Horowitz originally talked about, it's working through these stuck points that became critical. So in our model, we do cognitive reprocessing, and we spent a lot of time on these stuck points, helping the person cognitively resolve that. And this is a necessary component, but not a sufficient one.
Although I just want to throw into that I think there are still a lot of places and professions and circumstances in which people, even who've been through traumatic events side by side with one another, don't feel able to talk about what's actually happened. So it's like they share the same reality, but it feels impossible to talk about that reality. So, they turn to things that will anesthetize them. And one thing that's anesthetizing is, in an odd way, keeping the same level of intensity going so that you never actually have to feel about prior events. You just keep on putting yourself metaphorically, if not literally, in the line of fire. And that's problematic, where you all go out and drink together, not talking about what happened, but as kind of a shared ritual. And it's like, developing perhaps alcoholism and drug addiction. And over time, I think that what we've seen is people who've been here working on war trauma and their experience of every other person in their group that was deployed with whom they were, serving daily. It's like one by one, people suicide. It's like leaves falling off a tree. And so I think that I still don't want to underestimate the degree of silence that attends trauma even now.
Okay, so now we're going to turn the lens a little bit different, which was that in our original work, we had a dissociative disorders unit. And so people refer from all over the country with dissociative symptoms and disorganized attachment. And we began to recognize that one of the problems in working with the client is that oftentimes the part of self that was injured is not the part of self that presents itself for therapy. And so the person would come in with what was called in the psychoanalytic literature a false self, an adaptive self, somehow an imposter that the person had put up like a mask to present to the outside world to cover up the feeling of incredible inadequacy on the inside. And so they would end up doing everything we asked them to do in therapy, like a parrot, and be a good patient, but they wouldn't get better. And so the question is how to be able to recognize this false self and to be able to access in your 50-minute hour the injured self that really needs the repair. And that was the dissociative lens that we began to look at, which was if there is disorganized attachment, and dissociation is the pathognomonic feature of disorganized attachment, then there's going to be a fragmentation of the self system. Now, this is what I want to say, that the key to doing trauma work is recognizing that it's a disorder of self. And the real repair comes not in trauma resolution therapy, but in beginning to seed the development of the real self, which includes, in interpersonal neurobiology, some integration of these self systems that have become separate. Why they become separate? Well, a child who's, let's say, sexually abused at home and then has to go to school and learn their arithmetic tables become virtuosos in dissociation, and they can change internal states incredibly effectively. And when they're able to do that, it's a defense. And probably there are neurophysiological correlates of that, but then they become too good at separating. And therefore, a part of self can feel tremendous self-hatred, and another part of self can feel grandiose. And the grandiose part may present to the therapist in a narcissistic way, but the injured self never comes into the therapy room. So the question is, how can you access this injured self and do therapy with the right patient?
So, again, just to frame it in a slightly different format, there are many other things that can happen that cause fragmentation that don't result in full-fledged dissociative disorder or even all that many noteworthy dissociative symptoms. So I think that in future years, what will happen is that people will understand that sometimes in order to deal with contradictory circumstances, and I think many people actually do understand it, like in self-psychology and other realms, that it's possible to create whatever is necessary to get the resources that are available within the attachment system. So a person disowns aspects of self that don't net them anything usable and overdevelop perhaps aspects of self that get them approval or sometimes even get them negative attention when the choice is no attention versus negative attention. So parts of self get overdeveloped and parts of self get underdeveloped. And so then often people who overfunction succeed, quote unquote, in an external way, but internally they feel an estrangement from even their own success, even their own achievements, because as I believe Winnicott and Masterson both noted, only the real self can actually take in and absorb the positives that happen. So I think that there are a lot of people in the world who look outwardly successful, but who internally feel as though it's meaningless and it's never enough. And I think there are many things that can happen that are less than what would be classified as trauma that can create that internal divide. And I think bridging those internal divides and creating a framework in which a person begins to work toward accepting all parts of self is actually a huge cornerstone of mental health.
So the question is, how does one see the development of the self system and integrate? And the basic idea that Dick Schwartz originally was that we're all born with self, and that what we have to do is look at the blocks that keep that development from integrating and unfolding in a reasonable way. So some part of working with disorganized attachment has to do with being able to get an integrated personal narrative that the person can begin to. So narrative therapy approaches are pretty profound for this. Kathy Steele and some of the Dutch, van der Linden and the other began to write about what was called structural dissociation. And that really helped the field, because in structural dissociation, it was separated from kind of the dissociation of leaving your body during trauma. And structural dissociation had more to do with the fragmentation of the self system, and was borrowing on some of the original work with ego state therapy by Watkins and Watkins, that there are these, parts of self. So the addictive personality seems to be about having a lack of internal integration. And there's like this black hole in the middle of your stomach. And the more you have, it doesn't fill the hole. Like Lori's talking about, you keep achieving, accomplishing in a perfectionistic way, but it never seems to. So I've got this metaphor of sort of a cup that doesn't have a bottom in it. And you keep pouring stuff into the cup and it just comes out through the bottom. And that's that black hole that I'm talking about. And so what occurs when there are split off ego states is the addictive personality. And, so many of the people we're seeing, they're addicted to alcohol, they're addicted to drugs, they're codependent, all these multiple addictions. And the addiction treatment programs were trying to put a bottom in the cup by getting them sober, but they weren't really dealing with the bottom of the cup, because the bottom of the cup has to do with seeing the real self. And so the dry drunk is really a person who cannot connect to others. And it's in allowing that person to begin to develop, you got to have an I before you have a we. So the work had to be more internal than it was external. And so the idea was being able to have a person develop empathy for self and a secure attachment with self as a requisite for beginning to develop secure attachment with others. And that became the focus of our attachment work.
Well, I think also just to integrate it with addictions, the addiction field somewhat, the addiction field often talks about a person being a human doing rather than a human being, which I think is probably a very crucial concept. And so, for example, clients will say, well, I used to self-harm as an adolescent. I cut on myself. And then when I was in college, I found myself having random sexual experiences. I don't even know exactly why. And then later in life, I had an eating disorder or some other addictive disorder. And now I just overwork. And, that's a more socially acceptable way of doing the same thing, which is I'm still avoiding feelings, but at least I may not wind up in a treatment center this way, which I don't know that that's actually a useful goal. So in this case, the person actually realized that their overwork and their overfunctioning was in many ways as detrimental to their health and to their ability to create an intimate relationship with other human beings.
Okay, so if there is PTSD, there is dissociation. And I think a lot of trauma therapists have not been trained in dealing with these internal self states and are unable to diagnose and recognize the dissociative features of their client. And so, I'll be working with a client and we do cognitive behaviorally oriented trauma work or EMDR, but it doesn't take. The reason it doesn't take is because the ego states that are separated, that are injured, have been disowned in a variety of ways. And they would have nothing to do with that part because it was weak, it was a victim, it was helpless, and you don't want to get near that part of self. And so the very first step in working with trauma is having the person work intrapersonally, meaning with the parts of self that they've disowned and that they've rejected, and beginning to find a way to integrate those parts of self.
So let's give a framework that is, and perhaps the most useful one for dealing in the realm of parts with people who are not necessarily diagnosed as dissociative. And that would be internal family systems. And Richard Schwartz, who founded internal family systems, really just started out doing work with family systems. That was his orientation. And he realized somewhere along the way, by listening to clients over about a 20-year period and actually listening closely, there was something going on that even when you changed the external family system, continued to perpetuate symptoms. And ultimately, he realized that there's something going on internally, often that mirrors what was once going on externally. And he called it internal family systems. And as Mark said, the concept of internal family systems, which I'm going to make far briefer than what it deserves right now, just for the sake of time, is predicated on the idea that everyone has a self, capital S self, which is essentially soul, if you'd like to think of it that way. It's, a source of wisdom and knowing that is not attached to creating a particular outcome. And so it's a vast reservoir when it can be accessed for healing. It's better than any therapist. And when good healing occurs between clients and therapists, it's usually because the therapist self is in the lead and it helps the client to connect with their internal source for healing. Then further, Richard Schwartz identified, in addition to the capital S self, that parts are normative, which is the same thing Watkins and Watkins were saying with ego states. It's not just trauma that creates parts, it's normative. And that, well, as people said, even in the dissociative field or the ego state field originally, the problem occurs when parts of self are estranged, much like in a family system, or cut off, or fragmented, or create a closed system that's impervious to new possibilities. So what Dick Schwartz talks about that has to do with that in a way that conceptually I think is actually extraordinarily accurate is that often parts of self are exiled because, again, it's the same process as the disowning. It's a part that can't afford to be kept around. And often it becomes loaded down with lots of feelings and beliefs that would make functioning in a given environment difficult. So parts get exiled. And sometimes these are the parts of self that are maybe the most loving and the most affiliative, that are the ones that take on, shame and self-blame and that feel needy. And then what people do is exile them, put them metaphorically in the basement lock them in a cell, and hope they never emerge. And it's interesting that things in life which can cause them to emerge, because trauma can be one, but falling in love can be another, where there seems to be a renewed chance. Good therapy actually can be one, where again, there begins to be hope of some acceptance. But if the system functions in the same way it always has, that becomes impossible, because there are what the internal family systems model calls protective parts. And there are two kinds. One are preemptive managers, and the other, oddly enough, are called firefighters. They're reactive. So often what Dick Schwartz would say is that we all have manager parts. They could be workaholic parts that keep feelings at bay, that the exiles hold by keeping us busy. Or it can be an anorexic part that's not going to allow feelings in the body, because that would come from food. They can be obsessive compulsive parts, which think that if they can anticipate everything that might go wrong, then they'll never have to be painfully surprised again, as in the past. And so they just, worry and think and ruminate all the time. So there are many different kinds of managerial parts. But when these approaches almost inevitably don't hold, then what's called firefighter parts come in, and they're reactive. So again, let's say you fall in love, and your exiles really want to come up from the basement because they're like, oh my God, I need love so much. And they're like, I don't know, puppies or kittens. They come up inside you, and then fear sets in, because everyone wants to be seen and known. But when there's enough shame and self-hate attendant upon one's sense of self, one is also very afraid to be seen and known. And so, what may happen is that a person says, oh, well, sure, let's get involved. But then their manager, which is compulsively caretaking of everyone else in the world but them, starts to compulsively caretake the partner. But then intimacy continues, and they're like, oh my God, I have to get out of this. It's not necessarily a conscious thought, but it's the thing that happens when people find themselves sabotaging a relationship that they very much wanted, and accidentally helping to create the very outcome they feared the most. So working with these protective parts to get them to allow access to the exiles, and to be able to then connect the self of the person with exiles one at a time, so that the exiles can be actually witnessed by the self, and can go through a process that truly allows for healing of past experiences that remain unhealed. And literally, past feelings and beliefs can not only be cognitively restructured, but the charge related to them can truly be unloaded, so that a person no longer has the same triggers as before, and much more becomes possible that way. And then the focal point of healing is truly within the person. The therapist certainly can assist with how that can occur, but it's truly the self that's doing the healing.
Okay, so we're out of time, so I want to take some questions, but we'll go ahead and continue this next month, and we'll be able to integrate attachment therapy with parts therapy, and then add to it some of the new work with mindfulness and somatic work, which we have not yet talked about, and help you get more of an integrated approach to how we work with trauma. So we've sort of set it up now, and now we've got to sort of pull it together. So let's just see if there's any questions. Are there any attachment trainings or seminars that you recommend? Yeah, I recommend Dan Brown. He has attachment training that is unbelievably good. And Janita Fisher is just terrific. And she has a 10-hour course also. So they're the very best that I've seen. I'm sure there are many, many others. But Peter Fonagy is my favorite person to watch. He's just incredibly articulate, if you ever get a chance to see him. Well, I want to thank you all, and I hope some of you will write to us, and we'll list our email, and anything that you feel, like we've said, that you think is off. I'd love to have your feedback, because this is an evolving field. And we thank you all for attending. It's great.
Or anything you feel is on. Feel free to write that too. Okay. Thank you.